Hello, everybody. Good afternoon. I will give everyone a chance to make sure you're all in the room before we start. Hello, welcome to the latest in public health research series today. We're happy you're here. Just going to wait another little bit to make sure everybody gets in. I hope you can hear me okay. Today we are very fortunate to have Dr. Brittany Bustamante presenting. She is our UC President's Postdoc Fellow in Environmental Health Sciences here at Berkeley Public Health. And she's the PI of a recently awarded NIH Career Development K01 Award, which is super exciting, and about to start next summer as an assistant professor in the Department of Epi and Biostats at UC Irvine. So congratulations to Brittany. Her research currently focuses on fungal diseases and other emerging infections with an emphasis on how healthcare access, structural factors, and environmental exposures shape who gets sick, who gets diagnosed, and who survives. And today, she's going to present her work using agent-based models to evaluate bias in EHR data, testing how patterns of healthcare seeking, diagnosis, and recording can systematically distort estimates of disease burden and risk. So thanks so much, Brittany, for being here, and take it away.
Thank you. Okay, let me get my slides set up. And okay, let me hide this. So thank you so much for the introduction, Lauren. I'm really excited to be here today and to talk with you all about a project that I recently completed using agent-based models to examine the potential influence of bias in observed geographic disparities when you're using electronic health record data. I first wanted to just take a quick minute to see if anyone on the seminar today happens to recognize this image that's on my title slide. If you do, you can put it in the chat or you can come off mute and say it, and I'll just wait a couple seconds to see if anyone knows what this is. Okay, I'm not seeing anything, I'm not hearing anything, so let's see. So this is Thomas Schelling's segregation model, which he put forward in the early 1970s. And it's a very simple simulation demonstrating how collective segregation can emerge from individual mild preferences rather than any one person having very strong prejudice. And it's probably one of the most famous agent-based models. So it's just kind of a primer introduction to agent-based models. So objectives for today's talk. My hope is that by the end, you're able to explain why healthcare seeking behaviors may bias EHR-based estimates of geographic disparities in disease, that you can describe the agent-based modeling approach generally, and that you're able to discuss how the ABM approach can be adapted to other conditions or research contexts. So the project I'm going to talk about was recently published in the American Journal of Epidemiology, and I just wanted to post this here. So if you're interested after my presentation, the paper will go into more detail than I can today, and it also has a link to the GitHub where you can access the code and the repository. And I'm first going to talk just a little bit about the disease of focus for this paper, which is Staphylococcus aureus. So for those unfamiliar, Staph aureus is the most common cause of skin and soft tissue infections. And while methicillin resistance, which is what we call MRSA, methicillin-resistant Staphylococcus aureus, has decreased in recent years, it's estimated to be present in between 40 and 77% of all S. aureus SSTIs. In California, we track invasive MRSA infections that occur in inpatient settings, which is in the hospital, but the prevalence of community-acquired Staph aureus SSTIs in outpatient settings was relatively unknown. So last year, I published this paper in BMC Public Health, documenting the geographic variability in Staph aureus suspected diagnoses occurring in California emergency departments. And the spatial pattern was really different than I had anticipated. So rather than being concentrated in the dense urban areas of the state, which is what we saw at the height of the community-acquired MRSA epidemic in 2010, we saw way more diagnoses occurring in mountainous and rural parts of the state. And so the question naturally then became why? Was the spatial patterning due to uncontrolled or unmeasured bias in my data? Was it due to healthcare access or seeking since I was using EHR data, population structure, or some characteristics of the natural and built environment? And so today I'm going to walk through a project kind of assessing the first three of these bullets. So why does healthcare seeking matter when you're using EHR data? Electronic health records, or EHRs, are the digital records that healthcare providers keep on their patients. And I'm sure that everyone on the seminar today has interfaced with EHRs in one way or another, either as a patient, as a provider, or as a researcher. They include information like diagnoses, prescriptions, lab results, and hospital visits. And because they're collected routinely and they contain vast amounts of health-related information, also because they're cost-effective for researchers, they've become a really valuable source of data for population health research. But there's a really important caveat, and that's EHR data, or EHRs only capture people who actually interact with healthcare systems. And not everybody does this in the same way. So healthcare seeking behavior varies by geography, by socioeconomic conditions, and by individual preferences. And what that means is that what we see in EHRs isn't necessarily the true distribution of disease. It's the distribution of who shows up in the healthcare system. And that can bias our estimates when we try to look at geographic patterns. So let's say that we have two populations here, A and population B. And in population A, 3 out of 5 people have the disease that we're studying. And in population B, 3 out of 5 people also have the disease that we're studying. In population A, all 3 of those people have the ability and motivation to seek care for their disease. But in population B, only 2 out of the 3 people have the ability or motivation. So when we essentially condition on healthcare seeking just by using EHR data, it will look like population A has a higher prevalence, incidence, or whatever measure you're evaluating than population B, even though in reality, the two populations are the same. So observed cases in EHR may misrepresent true disease burden across regions. So what does that mean for geographic disparities? Well, if people in one region are more likely to seek care than people in another, EHR data will make that first region look like it has a higher disease burden, even if the true prevalence is exactly the same. In other words, the hotspots that we see in EHR data may not always reflect where disease is actually more common. Instead, they may reflect where healthcare access is higher or where people are more likely to show up in the system. And this can inflate disparities where access or utilization is high, and it can mask disparities where access or utilization is low. And this creates a real challenge. So if we don't account for healthcare seeking behavior, we risk misinterpreting EHR-based disease patterns as disparities and potentially attributing them to biological, social, structural, or environmental differences, when in fact they may be artifacts of care seeking patterns or essentially our sampling process. So while EHR data is powerful, it's biased by healthcare seeking behavior, and we need methods to test whether observed geographic disparities reflect actual differences in disease burden, or at least methods that give us some kind of evidence that the observed disparities aren't entirely due to the sampling process. But the big elephant in the room and the big problem is that you don't have information on people who don't seek healthcare in EHR data. We don't know how many people we missed. We don't know what conditions they have, what their characteristics are. We just don't know anything about them. And that's really the motivation for this project. So using agent-based modeling to ask, are the geographic disparities we see in EHR data just artifacts of who seeks care? So in this project, I used a two-stage approach. First, I used agent-based modeling to simulate the healthcare seeking behavior among residents in a geographic subregion of California, where we saw a lot of heterogeneity in disease burden. So agent-based models are computer simulations that are used to study the interactions between people, places, things, and time. They're stochastic models that are built from the bottom up, and they can be used to explore the dynamic processes that shape the distribution of health outcomes. They're relatively new to public and population health, but they're increasingly applied to problems that arise from complex relationships that include feedback loops or spirals and are adaptive. I think the easiest way to explain what an agent-based model is to people who aren't familiar with the method is as a synthetic population you create that lives inside of a computer. It's very similar in concept to a video game that is probably before the time of most participants on the seminar, but I spent way too much time playing in high school called The Sims. And so I chose agent-based modeling because we want to model the healthcare seeking process, but we only have data on people who sought care in the EHR. So short of conducting a census of every resident in the study area and asking about their healthcare seeking behaviors, what we ultimately have is information on the population structure of the area that we get from census data and evidence from the literature on the factors that influence care seeking that we can identify using theory. ABMs then bring this information together by building the simulated population and giving the individuals or agents behaviors and actions, giving them characteristics and attributes, and placing them in the environments with the systems and structures of your choosing. So to operationalize agent-based models, you synthesize information and data across different sources, and this is really one of its big strengths. So this study relied on EHR-derived data from the California Department of Healthcare Access and Information, also known as HCI. HCI collects yearly patient demographic data, clinical visit details, and payer and facility information from every non-federal hospital that's licensed to provide emergency medical services in California. It's a comprehensive record of ED visits to non-federal general acute care hospitals across the state, and it contains about 5 million observations per year. So this is where the number of suspected community-acquired MRSA diagnoses in each geography comes from. I also used HCI's medical service study areas data, so also known as MSSAs. MSSAs are geographic units that incorporate total population, socioeconomic, and demographic data that's provided by the census, and it combines that with healthcare service and availability. It's basically meant to represent geographies where any individual living or residing within that geography is likely to seek healthcare. These geographies comprise one or more complete census tracts, and they don't cross county lines. So using this data, I basically rebuilt the MSSAs in the agent-based model so that each geography had the correct number of emergency departments and primary care physicians. I also used a variety of publicly available data at both the California state and federal levels, including California Health Interview Survey, which I used to operationalize what proportion of individuals living in each MSSA had health insurance, as well as a global propensity to seek care or put off healthcare. I used CalEnviroscreen for a post-ABM analysis that I'll talk about in a little bit, NHANES to operationalize the population at risk, since community-acquired MRSA is kind of a unique infection where you aren't at risk unless you're colonized by the bacteria. NHANES had a survey year where they did random sampling in the community for community-acquired MRSA colonization. And then census data make the socioeconomic and demographic proportions in each MSSA in the agent-based model match the observed proportions in the census for those years. So we're basically just trying to recreate reality for the years of our data in the agent-based model. And then finally, I used data from several sources in the literature to operationalize infection rate, infection duration, cure probability, etc. However, the most important was a study conducted by Wilder and colleagues that did a randomized survey asking participants about their previous experience with MRSA infections. So whether they sought care or not, and then also showed them pictures of different skin and soft tissue infections and asked them to rate how likely they would be to go see a doctor if they had this infection or this infection and so on. It also asked about barriers and facilitators to seeking care, and a lot of those like more qualitative things that we often have a really hard time incorporating into our quantitative analyses. So this table here summarizes that information, and these are the parameters that govern my ABM. So we have information on disease dynamics, such as the proportion of the population that's likely colonized with MRSA at any given time, the global incidence, the probability of curing the infection with and without treatment, etc. We have information on care-seeking behavior, like how likely someone is to self-care at home based on their income, access to care, and experience with previous infections or infection severity. And then whether someone is likely to choose the emergency department based on their insurance status and income or resources. So the ABM represents the null hypothesis in this bigger problem that there are no geographic disparities in community-acquired MRSA infection, okay? So the model assumes no baseline differences in infection rates. Everyone has the same probability of infection, because what we're really interested in and what we're trying to isolate is whether geographic disparities emerge from a homogeneous state based only on individual behavior and the social and built environment. Then I compare that to the disparities in the observed data to determine if the spatial patterning is due to bias stemming from differential healthcare seeking behaviors. So in the model, there's two types of entities. There's individuals, which are the active entities, and they're characterized by insurance status and type, as well as having an income above or below the federal poverty level. And then the MSSAs, which are the geographic spatial unit. And those have the number of primary care and emergency departments where an agent could seek care within their boundaries, and then a list of agents that occupy the area. A time step in the model represents 1 day, and I ran the simulations for 4 years to match the empirical data. So these are the types of transitions occurring in the model. You have agents who get infected, they make decisions, they get better or they get worse. And this figures in the paper if people want to view it in more detail. I'm just going to give you a very high level example. So we have a population of individuals, and some of them are going to get an infection. And when this agent gets an infection, they have to make a decision. Do I go and seek treatment for this infection, or do I self-care at home? But this decision isn't just random, right? So the health belief model will tell you that this decision is informed by an individual's perceived barriers for seeking treatment. So that's one of the constructs of the health belief model. So what's their insurance status and type? What's their income and the resources available to them? And do they even have anywhere to go? Do they have a healthcare provider nearby? It's also influenced by their perceived benefit. So what's the benefit of an action, which I modeled as their previous experience with infections. So if they had an infection previously and it cleared really easily, maybe they're less likely to seek treatment for subsequent infections. And then also by perceived severity. So how bad is their infection? And I modeled that by infection duration. If they've had it for a long time and it's not clearing, it's going to be more severe and they're going to be more likely to seek treatment. And I could have looked at all of these variables in isolation, right? I could have measured the impact of insurance status or type on MRSA incidence, or the association between income and MRSA, but these factors don't act in a vacuum. They are codependent on each other, and it's together that they give rise to this behavior of healthcare seeking, which is really what I'm interested in. So that's why I chose an ABM over throwing these in a regression model and just testing their association. So if in the ABM someone goes to the emergency department, then great, that's a reflection of who we would have captured in our observed data. But if they self-care at home, then technically in the real world, we have no idea about those people. We don't know who they are, we don't know where they live, we don't know how long they were infected, we don't know anything about them. And so the thing that's nice about ABMs is we have information about both of these situations. The ABM will tell us how many agents were infected, how many went to the emergency department, and how many self-cared at home. And we can compare that population or that proportion that went to the emergency department to our actual observed data. So that process is exactly what we built into the model. Using the values from the table that I showed previously, which is now up here in the left, We created an equation that assigns each agent a probability of self-caring at home, also known as SC, at each time step in the model. So you can see the probability of choosing to self-care is basically a function of whether the individual lives below the federal poverty level, has insurance, their previous experience with an infection in the simulation, and whether they have a healthcare provider in their MSSA that they can go to. Sorry. So at each time step, an infected agent in the model basically calculates their probability to self-care and updates the probability with new information based on what happened in the previous time steps. And you can imagine applying those same probabilities in a more traditional way, so like weighting the observed data based on who's likely to seek treatment. But the advantage of an agent-based model is that it's dynamic. Agents make decisions over time and based on past behaviors and experiences. So their choices ripple through the system in ways that static modeling approaches just can't capture. So we then multiply the probability of self-care, or SC, by a time decay function, which is meant to represent perceived severity. So the longer an agent has been infected, the more the probability of self-caring at home declines. And then we take the probability of self-caring at home times the time decay function and sample it from a Bernoulli distribution, where x equals 1 for self-caring at home and x equals 0 for seeking treatment. And you just do this over and over and over again. And I'm not going to go into the details of the other processes, but essentially at each time step, new agents are becoming infected, infected agents potentially seek treatment, and they eventually clear their infection, and then they have a small risk of recurrent or reinfection, or they continue self-caring at home and there's a chance their infection clears on its own, or it doesn't, and they're forced into treatment after 30 days. So you do that over and over and over and over again. And like I said, we ran the simulation for a 4-year period, and we did 1,000 simulations of those 4-year periods. And then you summarize your findings. So that's usually done with averages across the runs. And once you have the results from the ABM, you analyze that data to compare it to the observed data. So ultimately, we want to estimate the effect of healthcare seeking by analyzing the spatial patterning produced in the ABM. So first, we identify geographies where the number of ED visits from the ABM, which I call the expected ED, was statistically significantly less than the observed data, which I call the observed ED. And I did this using Monte Carlo pseudo p-values. So on your left here is the observed ED. So this is the patterning in the empirical data. And on the top right map is the infection prevalence from the agent-based model. So it ranges from about 7 to 15%, and it's pretty homogeneous, right? And that's what we would expect, because remember I said we're assuming no baseline differences in infection rates. And for the most part, there's not much spatial patterning in the differences. But then you get down here to the ED probability. So this is the proportion of infected people in the ABM population that went to the emergency department. And you start to see some patterns arise. You see high probability of agents seeking treatment in the EDs in these bright red geographies, and low probability in these darker red geographies, which doesn't really look like the observed data. So this map is showing the p-value from the statistical comparison of the community-acquired MRSA cases that appear in the emergency department from the ABM with the observed data. So areas that are bright red are where the ABM produced statistically significantly fewer ED cases than the observed data. And you can see the ABM predicted significantly lower cases in these bright central MSSAs than what we saw in the observed data. So then I used Kendall's coefficient of concordance to measure agreement and qualitative patterning of infection prevalence. And this is a method that's usually done to inter-rater reliability in surveys and in systematic reviews and things. But I adapted it to basically answer this question of maybe the ABMs didn't quite get the magnitude of infection presenting in the emergency departments, the same as what I saw in the empirical data. But if I were to just rank these from highest prevalence to lowest prevalence, did it get that ranking or that patterning right? Is there agreement there? So this is a table of the geographies, and it has columns that show how each geography ranked from highest to lowest prevalence in both the observed and the ABM data. And when comparing the rankings using Kendall's W, I got a statistic value of 0.51, which was not statistically significant. So the ABM, when ranking the geographies from highest prevalence to the lowest prevalence, was not in agreement with the way they were ranked in the observed data. Then I used random forest algorithms to explore and rank the most influential parameters from the ABM. So random forest algorithms identified community colonization as an influential variable. And unfortunately, there's a lot of uncertainty in this value, which, like I mentioned, is the population at risk. So we don't have a really good understanding of what proportion of the population carries MRSA on their skin, since you can carry it and not get an infection, and there's just not a lot of random sampling being done in the community. So like I mentioned, to try and address this, we started with a value pulled from NHANES for the years where they did do random sampling in the community, and then we varied that until the overall aggregated infection rate for the entire study area was similar to the observed data. And then finally, I did a partial least squares analysis to conduct a relative importance analysis, or I used partial least squares to conduct a relative importance analysis, and identify the potential key drivers explaining the geographic level observed ED prevalence. So I looked at the influence of age distribution, environmental degradation, poverty, percent of individuals identifying as non-Hispanic white, the output from the ABM, which is representing the propensity in each MSSA to seek healthcare, the percentage of the population in each MSSA that are immigrants, and the percentage of household crowding. So the partial least squares analysis suggested that percent poverty, percent non-Hispanic white, and the average environmental degradation were potentially important variables in explaining the observed community-acquired MRSA ED prevalence. And in a follow-up study, I did a causal mediation analysis where I actually evaluated the explanatory factor or explanatory power of each of these variables. So combining the results, the emergent property of the ABM did not appear to replicate the observed ED data, and because Kendall's W was insignificant, we ultimately concluded that healthcare-seeking behavior alone may not be enough to explain the geographic disparities in community-acquired MRSA that we saw using the observed ED data. And then I wanted to just touch on some strengths and limitations of this project. So the model was informed by the literature and empirical evidence where possible. However, community colonization was identified as an influential variable, and we did try to tailor or to like vary that to make sure that we were assessing all of the different potential outcomes and emergent properties of the ABM using different values of that variable. Like I mentioned, we tried to address it using the NHANES value and then altering it, but ultimately there's just still a lot of uncertainty in that. Also, I only ran simulations for a subpopulation of California, so the results might be different if I looked at a different geographic area. And then our PLS analysis was conducted at an ecological level, but like I mentioned, I did a follow-up and causal mediation analysis, looking at the explanatory factor of those variables. And then finally, while I had to make simplifications and assumptions to model the healthcare seeking behavior process, a key advancement of this work is the development of an agent-based model that can test this hypothesis in a controlled environment. And to the best of my knowledge, this is really the first time that an ABM has been used in this way. So just to recap one last time, EHRs are a powerful research data source, but they reflect both disease dynamics and healthcare system dynamics, and it can be really difficult to separate those. ABMs provide a platform through which we can simulate and try to disentangle those processes. And this can help improve inference by revealing when observed patterns are likely due to underlying social, structural, or environmental processes versus when there is evidence that they can partly or mostly be attributed to healthcare seeking bias. And ultimately, their strategic use can support more valid disease models and surveillance. So I tried to keep it kind of short so that we would have lots of time for questions and discussions. But yeah, thank you, everyone. That's all I have. So.
Great. Thank you so much, Britt, for sharing that work. It's really impressive. So we really appreciate it. There's one question in the chat from Ken. Is an agent-based model similar to a synthetic control arm in clinical trials?
Mm, I I wouldn't say so, no. I mean, I guess it can be. So an agent-based model can really be whatever you want it to be, right? Like it's whatever you create it. And so it's possible you can make it reflect a synthetic control arm in clinical trials, but that's not how it's often used. Often it's used to recreate like pandemics or disease spread, recreate outbreaks, look at the impact of policy interventions and test different policy interventions as like a toolbox. I used it in this way, which was kind of a novel method or a way to use the method. So the thing that's nice is, yeah, it's a very flexible method, and it's whatever you create it to be. So it can be similar, I guess, but it's not inherently similar to a synthetic control arm, if that makes sense.
Great. Thank you. Other questions? Feel free to post in the chat or feel free to unmute if you have questions. Let's see. Do MRSA infections tend to result in an ED visit, or what is the role of non-ED outpatient visits?
So there's a lot of evidence that the majority of community-acquired MRSA infections are treated in the ED. And partly that's because of the population that's most at risk for MRSA, and partly that's because of and those populations use the ED more often than primary care. And also, I think kind of innately people who put off seeking treatment are end up with an infection that is more severe than a primary care provider can treat. So a lot of in order to treat a MRSA infection, you have to open it and clean it out. You have to like break the abscess and clean it out. And a lot of primary care providers, this has probably changed in recent years, but didn't always feel comfortable doing that. So even in my discussions with clinicians, they've said like a lot of primary care providers, even if someone went to see them with a community-acquired MRSA infection, they would refer them to go to the ED to get it cleaned. But that's not to say that people don't go to their PC for a MRSA infection, and we do know that that obviously people are doing that, but in the literature and from my kind of anecdotal conversations with a lot of clinicians, there is kind of a consensus that the majority of cases that are seeking treatment in the emergency department.
Great, thanks. And there's another question. Was the choice to work with healthcare seeking behavior versus something like health access barriers a label difference, or are there definition differences between seeking behavior and barriers?
So in my mind, seeking barriers is a component of seeking behavior, right? So seeking behavior is an individual action, and barriers is a systemic and structural level determinant. And your healthcare access and the barriers that you encounter is going to influence your individual personal behavior and whether or not you seek care. And agent-based models occur at the individual level, right? So each agent represents an individual and they have to make a decision on their behaviors. So access and barriers are included in the ABM and modeled as like having a healthcare provider that you can reasonably visit or drive to, having insurance, right, which is an access or barrier construct. And those things are influencing your individual behavior, which is what I'm ultimately modeling. So I don't know if that helps or makes that distinction a little more clear.
Great, thank you. And Tin has a question. How computationally intensive is this method?
It's very computationally intensive. So the best agent-based models are ones that can recreate complex behavior with the simplest rules. So in the shelling model, right, the one that I showed the photo of in the very beginning, that's one of the most famous ABMs, agents have two rules. So at every time step, um, they look around at the people that live near them and they decide whether or not that proportion is above or below a certain like tolerance threshold that the researcher assigns. And if it's above that threshold, they move. And if it's below that threshold, they stay where they are. And basically what the segregation model showed was you can have very like low tolerance thresholds, right? Of like propensity to move. It could be, I think it was like as low as 8%, like an 8% probability of moving if the majority of people around you are blue versus red. And you can still end up with these like very intense segregated communities. So it's a super simple model and it demonstrates how easy it is to end up with these complex patterns of segregation. And part of that is because it is so computationally intensive to run these models. So the more complex it gets, the more, yeah, like computational power that you need. So it's really, you have to make a lot of simplifications and you have to try to think like, how can I recreate this emergent property that I'm interested in like reproducing or creating using the simplest agent rules and like um, steps, basically.
Great, thank you. Sally has a question. Is the agent-based model similar to G computation, which also involves using models to simulate longitudinal data, but the parameters of the model are estimated from fitting the models on the observed data, which I think is not the case here. I know you didn't want to get too technical, but in the simulation, how did you choose or estimate the parameters in the model?
So it's not the same as GComp. So
Okay.
the in an agent-based model, I guess I'm not sure what you mean by estimate the parameters, which parameters, if you can clarify. Um, but in an agent-based model, you're not fitting anything, right? You're not fitting anything to observed data. You're basically programming rules, characteristics, behaviors, different probabilities, and then you're building a foundation, and then the agents have agency and autonomy, and they go through each time step. They go through the series of steps that you program for them, but then they learn from their past behaviors, and those behaviors ripple through the system and create this emergent property. She answered in the simulation when you're simulating healthcare seeking behaviors. Okay, so the coefficients for the equation basically that was programmed in come from the literature and um, in different surveys. So I had posted that like evidence table, and the evidence table has all of the parameters that govern an agent's decision-making process, and then the reference basically to where I pulled that parameter from. But that's not the same as me fitting that parameter to data, right? It's you have to reverse your thinking. So when we do like traditional quantitative models, the data is already there and it's already happened, and we're fitting our model to that data. In agent-based modeling, we're going the opposite direction. We're building the foundation and then we're letting it, like this stochastic process, simulate over time to move to like look forward. So instead of looking backwards and fitting our model backwards, we're looking forward, and there's not really a model involved in that sense. We're not looking at like associations between variables based on observed data. So yeah, so they come from models, or they come from surveys, or they come from qualitative in like qualitative studies. They come from population-based estimates. Like ABMs can integrate data across basically every data type and every evidence type. They also come from just like expert review. So the time decay function one, there is no parameter for how likely someone is to, or what percent their probability of self-caring at home decreases every day that they have an infection, right? That doesn't exist. So that came from just like expert opinion and talking to people, and then varying that like in multiple ways to see how influential it was in our ultimate finding. So ABMs can integrate all of that data, and then yeah, you put it in at the beginning and you kind of build this foundation, and then it goes forward looking instead of backward looking, I guess.
Great, thank you. Are there any other questions? All right, well, thank you so much, Britt. We really appreciate you sharing your work. And I see your email is there. So if anybody has oh, Ken has another question. Ken, go ahead. Sorry.
Hi, sorry.
That's okay.
This model, this effort is partly motivated in the idea that you could use it to inform policy decision making, and it's also founded on the idea that people would choose not to seek medical care. How difficult or how practical would it be to incorporate choices around societal factors like ICE raids and Medicaid, Medicare cuts in coverage, because those are very important variables, and I think it would be helpful to inform policy choices if you could model that kind of stuff. But I don't know how computationally difficult that would be.
So it's definitely possible. I mean, anything is possible.
Mhm.
You have to break things down into like measurable steps. So basically, in terms of like Medicaid cuts, right? So it's
Mhm.
possible people actually use ABMs to kind of test like hypothetical futures of what would happen if 10 million people lost health insurance. What would happen if this many people lost health
Uh-huh.
insurance? Um,
Right.
and so you can do that sort of thing pretty easily in an agent-based model, and rerun the simulation to see how the outcomes change in these different scenarios. Things like
Mhm.
ICE raids would be a little, I think, more challenging to model just because it's harder to break that down into actionable steps at each time step. And it's also hard to really understand how that influences agents' behaviors because it's so multifaceted, right?
Right. But that's a key issue because, and it's not the ICE raids themselves, right? It's the fear that creates in people's minds that, they don't want to go out for groceries, but, what level would they, would they consider it important enough to go to the emergency room or seek medical care when they know that data could feed into ICE databases. So there's a series of utilities that for them that have to factor in those decisions, and that could be it could be very revealing, but I can also see that it being really computationally intensive and potentially intractable from a mathematical point of view. So I just wanted to see what your thoughts were on the practicality of incorporating that kind of stuff.
Yeah, I mean, if you can make the problem simplistic, right? So like if we kind of compare it to the segregation model, right? So if we were to give an agent a differing probability of like, okay, if this many ICE raids have happened in their neighborhood in the last like whatever time period, and their probability of seeking healthcare for a major like medical event is 8%, then this is kind of what that would look like. If it's 10%, then this is what that would look like. If it's 30%, this is what that would look like. And so you kind of pick these different scenarios and then you just run it and then you look and see like how that changes and ripples through the system. So if you can break it down to something tactable and like measurable like that, then it's very feasible. but it ultimately depends on what the end goal is, like what you're trying to recreate or replicate or produce in the emergent property. Like what's the outcome that you're looking at? So are you looking at patterns of healthcare service utilization then? Are you looking at like patterns of like missed care, and how are you ultimately using that information, if that makes sense? So really like how you break down the problem into simple steps for the agents to like create, to go through each time step depends on what your input is. So
Thank you. That's very helpful.
Great. Thanks so much. Thanks, Britt. Great. Any other questions? Really appreciate everyone being here today. And thanks again, Britt, for sharing your work, and best of luck in your next project. Yeah.
yeah, thank you
All
everyone.
right. Take care, everyone. Have a good day. Bye-bye.